My name is Mikael Landén. I'm a psychiatrist, professor of psychiatry. I defended my thesis on transsexualism in 1999. That is not my main field anymore. I work with bipolar disorder, but I see gender dysphoria patients once in a while still. And it will be apparent why I am here. So just a brief history. Up to the turn of the century, we did as everybody else. We had the predominant approach for children with watchful waiting. No medical intervention was provided. And then this changed, of course, around the early 2000s. And there was one Professor Rydelius, and his name will I return to, in Stockholm, who implemented the Dutch protocol in Stockholm. And in 2015, we had formal guidelines issued by the NICE equivalent in Sweden, called the National Board of Health and Welfare. And the recommendation was, at that time, healthcare should offer puberty-blocking hormone treatment to young people to reduce their suffering. And then this happened, of course, in Sweden, like everywhere else in the Western world. We saw this dramatic increase. On the left-hand side, you have the incidence of gender dysphoria, all ages, and on the right-hand side, up to age 19. And the upper line is both sexes, and then second girls, and at the bottom boys. So the same thing as everywhere else. So I wrote an article in Swedish in our medical journal where I said that this increase of gender dysphoria requires consideration like we would do in any other case in the medical world. We see this 2,300% increase since 2010. And I discussed some of the unlikely, in my view, causes that had been put forward. And one was, in Sweden, policy changes that we had done, which is very unlikely given that we, during the exact same time period, see the exact same change in the UK, in the United States, Netherlands, and Norway, and Finland, and so forth. Another explanation for this change was that attitudes towards gender dysphoria people would have changed around 2013 and 2015. And I have no data to disprove that argument, but I did actually survey the attitudes in Sweden back in 2000. We sent out a questionnaire to 1,000 people, randomly selected, and astonishingly 70% responded. And the attitudes were overwhelmingly positive in terms of should transsexuals be allowed to adopt, to marry, to enter the workplace, and to work at preschool, and so forth. So I don't think that's a likely cause. More media coverage. Those of us who have been in the field for many years know that this has always been the subject of great attention. So I think that's unlikely too. Among the possible causes is diagnostic drift. We've seen the exact same phenomenon in autism in Sweden. This shows the increase in autism diagnosis in Sweden during the same time period. And also, of course, what Dr. Littman discussed yesterday, spreading this idea that gender dysphoria is an explanation for other mental suffering. But the most important thing is that the long-term outcomes are unknown, and in order not to harm, we should only provide this treatment in the context of clinical trials. So what happened then was that the government commissioned the National Board of Health and Welfare to update their guidelines. And in Sweden, we have a special governmental body called SBU, an HTA, Health Technology Assessment Organization, that conducts these reviews. And we did that and presented the results in 2022. That was in Swedish, which is why we also wrote it up as a scientific article. This is not an SBU publication. It's only the authors that stand behind this. But the authors of this paper are the people in the project group. And among them, Professor Rydelius, who actually, you might argue, had an intellectual conflict of interest because he was the one who introduced the Dutch protocol in Sweden. Yeah, but that would have tipped the conclusion in the other direction, so we haven't received any criticism for he being on board. So I will not bore you with this, but we followed the PRISMA protocol, and as is always the case, we start out with 16,000 papers, and we ended up with 24 that we could review, and the conclusions were, sadly, that there were insufficient scientific evidence to assess the effects of puberty blocking therapy on gender dysphoria, psychosocial functioning, cognitive function, body measurements, body composition, metabolism, whereas we found some evidence that puberty-inhibiting hormone therapy slows down the increase in bone formation, which is normally expected during puberty. That report went to the National Board of Health and Welfare, and they changed their recommendations. So previously, they said that health services should ensure that the treatment with puberty blockers is started without delay. And they reasoned that we know now that the occurrence of detransition exists. Hence, gender-affirming care can lead to impaired health and quality of life. It can harm. So we know that. We do not know that there are any benefits. So that tips the balance, and hence hormone therapy should not be prescribed except in the context of research and in, this term comes back, exceptional cases. So that's the current recommendations. I will go through some of the methodological problems that we identified during this work. So, of course, no randomized studies, no control groups, and several other presenters have discussed this, but this is one example, the Costa study from 2015, where they start with 436 people who are referred, of which 201 were included in the study. All patients improved after 6 months without any treatment. And then there were 80 dropouts, not accounted for. And then 60 patients start on puberty blockers plus psychosocial support, which makes it difficult to disentangle the effects of each of these interventions. And then they end up with 35 in the final evaluation. So 35 out of 436. And that introduces a risk of selection bias, of course. So a thought experiment. So you have 9 patients entering the study, and imagine that you're measuring GAF, Global Assessment of Functioning, for example, and the mean is 60. And then people drop out during the course of this study. Here is one patient, I just made this up, but one patient improves, but the majority just stays the same. And this is, and the average at the end of study is 88. So it seems like there has been an increase in global psychosocial functioning, which is, of course, only because people with low functioning dropped out of the study. I'm not saying that this is the case, it just can be the case. So we need intra-individual comparisons, and that has not been done, with the exception of the London reanalysis of data. The studies were few and small, and this is also an important problem. So regression to the mean. So in every study where symptoms can wax and wane, blood pressure, depression, I would say almost most disorders, not Parkinson, not Alzheimer's, but not all other, but many disorders, they peak and they disappear. And so people are entered in a study when they are at their worst, on average. And if you follow patients, they will always improve. And that is separate from the placebo effect. This is not a placebo effect. This is a mathematical phenomenon that you will always see. And that can also, of course, happen in this longitudinal study. And that's why you need a control group. Short follow-up time, of course. My concluding reflections are that there is no knowledge of what happens if the healthcare does not take action, or of course treat comorbid conditions, provide psychosocial support. We do not know if gender dysphoria in this new group remits spontaneously. And I think that is where the research should start now. We should follow patients for 10 years, I think, to see what happens. And if it's the case that 90% of all these patients persist in their wish to transition, then that's important information. But on the other hand, if 90% are perfectly happy, then we know that we should not treat this whole group the same. We need predictors for which patients will persist or not. If the outcomes would be the same without treatment, when people are 30 years old and the outcomes are exactly the same, do we agree that it would be better if we had not put patients on lifelong hormone treatment and surgical interventions? And finally, I belong to those who believe that there are people who benefit from sex reassignment, and I think there is a group. I don't know how we would identify those, but I do think that we need to safeguard the sex reassignment treatment for those who need it. And I fear that this indiscriminate use of hormone blockers in youth risks undermining the trust in the whole field. So the consequences might be that the whole idea of gender medicine is just pushed away and stopped. And that I see as a risk, at least. That's it. Thank you.